that's where we start, because any treatment that we give you will be better if these risk factors are improved. I'm going to move on to the second portion of this talk, which is to talk about catheter ablation. Catheter ablation is essentially using a small catheter to deliver energy to the heart to destroy the abnormal circuits of atrial fibrillation. This can be done with radiofrequency energy, which generates heat and burns and destroys the circuit. There is also cryoenergy, which is you freeze the tissue to destroy the electrical circuits. There's now another energy source that is called electroperforation, which is now just being worked on, and it has not been FDA approved. That may come on the scene within the next year or two. That may actually be safer than both of these energy sources, but that's still left to be tested. If you recall from the first couple of slides that I showed you, atrial fibrillation is this chaotic rhythm at the top portion of the heart. And I want you to focus on the fact that this is the left atrium here, and off the left atrium, there are these tubes. There are usually 4 of them, which are called the pulmonary veins. They return blood from the lungs to the left side of the heart where it's pumped to the rest of the body, and that's oxygenated blood. Within these tubes are little branches of electrical tissue that connect to the main body of the heart and represent the major source of atrial fibrillation in most people. This is a cartoon of the back side of the left atrium. Now I've cut away the rest of the atrium. The ventricles sit down here. This is the left atrium. These are the 4 pulmonary veins, the right-sided pulmonary veins and the left-sided pulmonary veins. There's little sleeves of electrical tissue that connect to the main body here of the left atrium. And you can get firing within these pulmonary veins that actually go very rapidly, 400 to 600 beats per minute, and trigger the heart to go into atrial fibrillation. What our goal with catheter ablation is actually to disconnect these electrical circuits, which actually generate atrial fibrillation early on, in order to prevent you from going into atrial fibrillation. And I will explain to you how that's done. Patient is brought into a cath lab, and this is a mock-up. We put them on a table, and then we insert a small tube in the leg area here, where we actually then introduce a catheter. We've gotten very sophisticated with our mapping system, where the catheter itself has magnets on the tip of the catheter, which can then give you a location. It's like GPS within the heart. Here is what we lovingly call the toilet seat that sits under the patient and generates a magnetic field. And that way we're able to see the catheter in the magnetic field. And we can record this and display it on a computer. This is a real EP lab. And as you can see here, there's a patient on the table. And there's me, there's the anesthesiologist. We use X-ray, but we have a large screen that displays the computer-generated image of the heart that we use to guide our ablation. And there are a number of things in this room, which is all really there for your safety. We also have a team within the EP lab that actually, it takes a whole team of close to 7 people to do this procedure. We have nurses that monitor you. We have an anesthesiologist, which is not shown. We have representative usually from the company that assist us with the mapping system because they become so sophisticated. And we have people monitoring and assistant that helps me with manipulation of the catheters. Here is sort of an early mock-up of what goes on when you have an ablation done. This is the catheter that's inserted from a leg vein, and it goes into the heart. And you can see the projection of that toilet seat we talked about. And we can project it on a computer screen, this catheter, and then we can move the catheter around within the heart. And here's a catheter coming up here on a cutaway of the heart. This is the right atrium here. You can touch various parts of the heart, and you can see that catheter projected here. If I move the catheter here, the catheter gets projected here. And then here's a catheter moved to the area called the coronary sinus. And we can project that on a computer screen. And essentially, we don't have to use much in the way of fluoroscopy. So here is generating a map of the right atrium of the heart, and just by moving this catheter around. The other thing that you begin to see here is colors. And the colors represent activation. It goes from red, yellow, green, blue. And the part here that's projected in red is where your sinus node is. Remember what I said? That's where the firing and the trigger starts. And then you can see the progression here: red, yellow, uh, green, blue, and then purple. And then here's the tricuspid valve, which lets the blood flow into the ventricle, and the electricity spreads from the top to the bottom part of the heart. This was an early, unsophisticated version of our mapping system, but it sort of really illustrates what we can do without using X-ray to do it. So how do we do an ablation? Well, we talked about those pulmonary veins. We come up from the leg vein in the groin, and then we insert a catheter through the right atrium, and then we have to go through the interatrial septum, which is a thin area that we puncture through to get across to the left atrium. Here are the four pulmonary veins. These are the left-sided veins. These are the right-sided veins, and you can see the opening here. We usually put a circular catheter into those pulmonary veins in order to record the electrical activity. We then go up with a second catheter, and that catheter is your ablation catheter. In this case, this is a radiofrequency ablation catheter, which delivers heat. And we essentially burn around the opening of those vessels to disconnect those electrical circuits that are superficially on the surface of those pulmonary veins. And we do that for each of the pulmonary veins. So after completing this vein, I would move this catheter down to the inferior pulmonary vein here, and then would repeat that around. It is a very tedious procedure, but we have a lot of sophisticated equipment in order to do this. What you can see here is we have this is a rendition of the heart that we actually build with our mapping system. This here is the left atrium. You can see the left-sided pulmonary veins, the right-sided pulmonary veins. We also have an ultrasound catheter that allows us to puncture that interatrial septum under guidance so that we're not puncturing outside the heart and causing a problem. As you can see here, the ultrasound, this is an ultrasound catheter. This is the septum. The right atrium sits here. These are the pulmonary veins that we're eventually going to ablate that's coming off here. But you can see we can visualize exactly where we need to go across the septum. We can also visualize where we're burning within the heart. But we also have even more sophistication here. Here is a 3D mapping of the left chamber of the heart overlaid on a CT. Here is your mapping catheter, and this is actually a real life case and what we see while we're ablating on the screen. We're burning, these are where your ablation catheter, and we begin burning around the outside of these veins. And while we're burning, we're actually recording the electrical signals that's within this. And the goal is to eliminate all the electrical activity coming from this vein. And with the three-dimensional mapping system, we can turn the map in any way we want. Here we are looking at it from the left side of the chest. And here is the ablation catheter that is the same catheter that's projecting here. And these are the radiofrequency lesions that we're delivering. When we get done, we pretty much go around the entire pulmonary veins, anteriorly and posteriorly go around the right-sided pulmonary veins, and we make sure that there's nothing coming out of these veins at the end. And that's really the basic things that we do for atrial fibrillation. Usually to create these lesions, it probably takes about an hour and a half, but the entire procedure can take anywhere from 3 to 4 hours. So who are candidates for atrial fibrillation? We have guidelines that are set out there by our national societies in terms of who are candidates for atrial fibrillation ablation. So anyone who is symptomatic, and when I say symptomatic, if you exhibit any of those symptoms that we talked about earlier, palpitations, chest discomfort, shortness of breath, or fatigue, you're considered a person who's symptomatic with atrial fibrillation. I can't tell you how. You're the one that determines how symptomatic you are and how badly it really affects your daily living. But for patients who have symptomatic atrial fibrillation, that is refractory or you're intolerant to medications. And remember, here it is, paroxysmal atrial fibrillation, the one that comes and goes. Most electrophysiologists and most cardiologists agree that you are a candidate for catheter ablation. There are other groups. Clearly, I think anyone with paroxysmal atrial fibrillation, whether or not they've taken drugs or not, or intolerant of it, is a candidate for catheter ablation. And also patients who have symptomatic persistent atrial fibrillation, and usually that's persistent atrial fibrillation that's usually less than a year, although there are some centers attacking permanent atrial fibrillation with catheters. I think that the results are very poor, continue to be poor. And I will sort of mention something about that when we talk about the surgical approaches, because I think the surgical approaches are very effective. And even they have their limitations in terms of how they treat permanent or long-standing persistent atrial fibrillation. Most of us also agree when catheter ablation shouldn't be done. Ablation should not be performed in a patient who cannot be treated with a blood thinner, because after the procedure, we have to treat you with a blood thinner for at least 2 months. Um, Ablation to restore sinus rhythm should not be performed solely for the intent of obviating the need of taking anticoagulation. So there are patients that we do an ablation on, and if your risk score is greater than 2, we will continue you on blood thinners indefinitely, despite having an ablation or an apparently successful ablation, because the problem is that there's a risk, 2, 3 years down the line, that you can redevelop atrial fib because of other triggers within the heart, and your first presentation may be with a stroke. We do take off those patients who are 1 or 0 off their blood thinners after a catheter ablation that's been successful. For patients who do not wish to continue on that, we have other treatments available, and that's where the left atrial occlusion devices come in. We keep a database at Sharp Memorial Hospital, and I've been keeping a database there since 2003. And we last sort of updated back in February of 2020. COVID has sort of stopped our follow-up for a little while. But what I'm going to concentrate on is the initial ablations, because we have a lot of redo patients or referral patients who had ablations also. But there are 696 patients who have undergone the initial catheter ablation procedure at our center. And as I said, we don't even count the redos, and there's equally a number of redos also. 466 patients are pretty much gone with the current approach that I described above. And we have 364 patients with 1-year follow-up, meaning February 2021, we have the last follow-up for those patients who entered that database. And the reason I show this is that we do keep 1-year outcomes on each of these patients. Of those patients who have 1-year follow-up, and our follow-up rate is over 90%. Overall, with no antiarrhythmic drug for paroxysmal and what I call short persistent patients, our success rate is 84%. Slightly higher for paroxysmal atrial fibrillation, slightly lower for persistence. Some would say these numbers are pretty good numbers, but it's also making sure that you select your patients carefully. We tend not to do anyone over a year with persistent atrial fibrillation. But I can tell you, when you look at people's number, you have to ask them, well, how often are you follow up? How often are you recording? These data, when we do our database, we do an EKG at first month, third month, 6 month, and 12 months. We do a continuous 21-day recording at 3 months, and then we have a follow-up EKG in a year. I can tell you that if you put implantable loop recorders and you follow these patients, you will find shorter or briefer episodes of atrial fibrillation, which may reduce the success rate. But you always have to pay attention to what someone presents to you when they say they have a success rate that is over 90%. That's very hard to achieve. Most of the time it's because they're not following up. But how do we get to these good numbers? Well, one of the things that I tell my patients up front, that close to 20% of patients, 20 to 30% of patients will need a repeat ablation. Some patients choose to have a repeat ablation. Some patients now decide, oh, I'll take the drugs because they're working better after the ablation. And it may be a combination of ablation and drugs for some people. But when we go back and looked at the database of the patients we just recorded, 17% of the patients had repeat ablation. Paroxysmal was 18% of the patients, persistent was higher, and that's expected because those are tougher and they have other areas of triggering. Like I said, when I talked to my patients initially, I said, there's a chance you're going to need a repeat ablation. This is another picture of the left atrium. And this is a picture of a patient that needs a redo. One of the things, I didn't show you the earlier picture where when we do a map of the atrium here, these are the left-sided pulmonary veins here, these are right-sided pulmonary vein. Usually it's all purple, and that's healthy tissue. When we do the ablation, what we expect to see is red, which is usually represents a disconnection of that vein where we've ablated all the signals within that vein. Here you can see on this pulmonary vein, there it's not all red. This is the area where we had a bit of a recurrence, and this patient came back for a second procedure, and all we did was just seal that one area, and this patient has done well in follow-up. And so it makes sense that if someone tells you that you have cancer and you need 5 cycles of chemotherapy, you're not going to stop at the third cycle. And I think that it's important that if you have a recurrence almost immediately within the first 3 months, that we don't even ask questions. We go back and we do a second ablation. What are the complications of atrial fib ablation? I think this is always one of the questions that I get in follow-up. So I decided to put the slide up here. There are rare serious complications of atrial fibrillation where you end up getting a perforation that someone needs to go to open heart surgery for, or you get one of the feared complication, which is an atrioesophageal fistula, where you get because of the burning over the esophagus on the back part of the wall, you can end up forming a fistula that develops 4 to 5 weeks after. Fistulas are very difficult to treat, and the mortality rate is high. Fortunately, we've done a lot of things to mitigate that risk in terms of monitoring the temperatures in the esophagus when we're burning near the esophagus, and we also now cool the esophagus. There's a 1 in 200 risk of stroke. This again is mitigated by the fact that we keep you now on blood thinners before, after, and before, during, and after the procedure. Any major bleeding from the groin is really rare. Most bleeding, since we go in the veins, we don't go in the arteries. This is the low pressure side. I can tell you I've not seen any significant pulmonary stenosis in the last 15 years. We do have a 1% risk of tamponade. When we're burning, we're trying to get a full thickness burn of the wall of the heart without going through. The risk of having a perforation with bleeding around the heart is about 1% or just less than 1%. And that's usually treated by putting a needle in and draining the fluid and leaving a tube in overnight. And most of those heal without having any other surgery. Sometimes we can develop different arrhythmias after surgery. Some of it may be because of the lesions we created, but most of the time it's because of the underlying problem. I'm going to briefly touch on the Watchman procedure, which many of you may have heard of. That's a device that is used to occlude the area where clots form within the heart. This is a non-surgical procedure. About 6 weeks after we put this in, there's no longer a need for NOACs or warfarin. The procedure time is 1 hour. And as I said, you're off anticoagulation in 6 weeks. Well, this is again the heart. This is the left atrium. There's an appendage or an area that hangs off here that when the heart goes into atrial fibrillation, it's no longer squeezing. It actually starts quivering. And with quivering, blood slows down and blood clots. And it tends to clot in a pouch of the heart called the left atrial appendage. And here's a picture of that left atrium. This is the left atrium here. The ventricles are at the bottom. This is the thing called the left atrial appendage. And why we have this left atrial appendage is probably the same reason why we can't understand why we have an appendix. We don't have a good reason why it's there other than to form clots. This is a ultrasound that shows a clot within that appendage. This is the appendage here, and that's a clot. If that breaks off, it then goes through the mitral valve and then goes to the systemic circulation where you can have a stroke to the brain or a stroke in any organs of the body. The Watchman procedure, essentially, the device itself is inserted to occlude that area so that no clots can form within that area that can break off. So it sort of sits there and captures and prevents clots from coming out of that appendage. It is put in somewhat the same way we do the ablation, up from the leg vein, cross the septum, and then we insert the device into the appendage here, and then the device is released. Over time, what occurs is that your body eventually forms a lining, and you can see this smooth lining, and this area is now occluded, and then your risk of having a stroke is the same as if you were taking a blood thinner, significantly less. So just to conclude this section on really catheter ablation and Watchman, which are really, I would consider we call them percutaneous procedures or minimally invasive procedure. For the majority of patients with atrial fibrillation, we can control atrial fibrillation with catheter ablation. And recall that we do catheter ablation to relieve symptoms. We don't do it solely to get patients off blood thinners because we can't always promise that. And the atrial occlusion device, which I just talked about, is now available as an option for blood thinners for those people who really want to get off blood thinners after an ablation procedure or even before they have an ablation procedure. I'm going to talk about the part that Dr. Limmer usually talks about. I'm not a open heart surgeon. Dr. Limmer is the open heart surgeon, but we've been working together now for the past 10 years on other approaches to dealing with our more refractory and difficult patients with atrial fibrillation.